Podcast 35, Week 37. Welcome to the podcast, Your Pregnancy Week by Week. This podcast covers the 40 weeks of pregnancy in 38 segments and is based on the book Your Pregnancy Week by Week by Dr. Glade Curtis, MD, and me, Judith Schuler, MS. The information in our books and podcasts is a general informative guide about pregnancy. None of the information we provide is intended to replace, countermand, or conflict with the advice given to you by your own doctor. Always follow his or her advice. Use the information you learn here as a starting place in your dialogue to help you put your pregnancy concerns, questions, or interests into words. The goal of every pregnancy is a healthy mom and a healthy baby. To that end, our podcasts cover many topics. In each weekly podcast, we'll highlight information contained in the same weekly discussion in our book. We suggest you read each weekly chapter to learn further information, such as how baby is growing and changing, and how you're growing and changing too. Our book also contains illustrations of changes in baby or you, advice for dads, charts, lists, boxes, an exercise for every week, a comprehensive glossary, hints, tips, snippets, and blurbs we just can't reproduce in a podcast. So let's get started on this week's discussion. We're going to look at week 37. The cervix is a tube that connects the uterus to the birth canal that baby travels through during birth. It usually becomes softer and thins out before labor begins or during labor. Effacement means the cervix gets thinner. Dilatation means the cervix opens. Effacement and dilatation may occur slowly over several weeks, but some women may need help from medications to get things going after their due date. You'll be checked to see if baby's head, bottom, or legs are coming first. This may be referred to as the presenting part. The station is then determined. Station describes the degree to which the presenting part of the baby has descended into the birth canal. Let's talk about cesarean delivery. Most women plan on a vaginal birth, but a cesarean is always a possibility. With a cesarean, the baby is delivered through an incision made in the mother's abdominal wall and uterus. An emergency cesarean delivery is one that is unplanned. An elective cesarean delivery is planned even if you'd rather not have one. The main advantage of a cesarean is delivery of a healthy infant. It may be the safest way for baby to be born. The disadvantage is its major surgery. It would be nice to know you're going to need a cesarean so you wouldn't have to go through labor. Unfortunately, we often don't know beforehand if you'll need one. Some women believe if they have a cesarean, it won't be like having a baby. That's not true. If you have a cesarean delivery and deliver a healthy baby, you haven't failed in any way. Remember, having a baby has taken 9 long months. Even with a cesarean delivery, you've accomplished an amazing feat. A cesarean delivery may be done for many reasons, including baby is too big to fit through the birth canal, you have preeclampsia, or baby is in a breech presentation. We've seen a rise in the rate of cesarean deliveries due to better monitoring during labor and safer surgical procedures. Part of the increase is also due to patient-requested cesarean. There are many reasons a woman may think she wants a cesarean delivery, including fear of labor, concern over vaginal tearing, and worry about incontinence. U.S. doctors are split on the question of elective cesarean delivery. There's evidence supporting both sides. Some believe with improved anesthesia, infection control, and pain management, a cesarean is no riskier than a vaginal delivery. Babies delivered by a scheduled cesarean between 37 and 39 weeks have more respiratory problems than babies born vaginally or by emergency cesarean at the same point in pregnancy. It's believed hormones released during labor may help baby deal with the fluid in the lungs. Additionally, the compressions of baby's chest from labor and delivery may help clear amniotic fluid from baby's lungs. Cesarean deliveries are done by a physician. Midwives are not qualified to do them, so if you have a midwife and a cesarean becomes necessary, a physician will perform it. In most areas, an obstetrician performs a cesarean. In small communities, a cesarean may be performed by a general surgeon or a family practitioner. If you will have a cesarean, you're first visited by the anesthesiologist to discuss pain relief methods. Up to 90% of all elective cesarean deliveries are done with spinal anesthesia, such as an epidural. After you receive anesthesia and everything is numb, your doctor makes a 5 to 6 inch incision in the area above your pubic bone through tissue down to the uterus. There, a horizontal incision is made into the lower part of the uterus. The doctor then reaches into the uterus and removes baby, then the placenta. Each layer is then sewn together with absorbable sutures. This will take 30 minutes to an hour. You're often awake with a cesarean. You may be able to see your baby immediately after delivery. You may also have a chance to begin nursing. Often, your partner can be with you during the procedure. You'll probably stay in the hospital 2 to 4 days. Recovery at home takes longer than recovery from a vaginal delivery. Full recovery usually takes 4 to 6 weeks. Some women who have a cesarean decide they want to try to have a vaginal delivery with their next baby. This is called vaginal birth after cesarean, or VBAC, VBAC. In some cases, you'll have to have a cesarean delivery. In other cases, you and your doctor may decide to let you labor for a while to see if you can deliver vaginally. Medically speaking, the method of delivery isn't as important as the well-being of you and your baby. The reason a cesarean delivery was done with the first baby impacts the success of a vaginal birth with the next baby. If a woman failed with induced labor, and that was the reason for a cesarean delivery, she is twice as likely to fail with VBAC with her second child. Some women like having a repeat cesarean because they don't want to go through labor only to end up with a cesarean delivery. There are some reasons a woman should not consider VBAC. If you're small and the baby is large, you may need another cesarean. Multiple fetuses may also make vaginal delivery difficult or impossible without danger to the babies. Inducing labor with VBAC may be necessary. However, this increases the risk of the uterine scar from the earlier cesarean stretching and pulling apart. A repeat cesarean may be advised to avoid rupturing the uterus. Risk also increases for a woman who gets pregnant within 9 months of having a previous cesarean. VBACs are safest when at least 18 months have passed between the previous cesarean and the attempted vaginal delivery. There are advantages to having a VBAC, including a decreased risk of problems associated with surgery. Recovery after a vaginal delivery is also shorter. If you've already had a cesarean and want to try VBAC, discuss it with your doctor well in advance so plans can be made. Consider the benefits and risks and discuss them with your partner before making a final decision. Ask your doctor his or her opinion of your chances for a successful vaginal delivery. He or she knows your health and pregnancy history. If you decide to try VBAC, you may have to deliver it at a different hospital. Not all hospitals are equipped for VBAC. Ever heard of an enema? It's a procedure in which fluid is injected into the rectum to clear out the bowel. Will you be required to have one? It's something to ask your doctor. An enema before labor can make the birth of your baby more pleasant. When the baby's head comes out through the birth canal, anything in the rectum also comes out. An enema decreases the amount of contamination from feces during labor and delivery, which may help prevent infection. Most hospitals offer an enema at the beginning of labor, but it's not always mandatory. Ask your doctor if an enema is routine or considered helpful. Also, ask about the benefits and the reasons for giving one. It isn't required by all doctors or all hospitals. Some women experience back labor. Back labor refers to a baby coming through the birth canal looking straight up. This can cause you lower back pain, which can last a long time. The mechanics of labor work better if baby is looking down at the ground so it can extend its head as it comes through the birth canal. If the baby can't extend its head, its chin points toward its chest, which may cause pain in your lower back. Your doctor may need to rotate baby so it comes out looking down at the ground rather than up at the sky. Remember, our podcasts give you the highlights of what may be happening in any given week. Check our book, Your Pregnancy Week by Week, for more detailed information. You may also want to check out our book for partners, Your Pregnancy for the Father-to-Be. It covers pregnancy from a man's point of view and provides lots of valuable information a man may find very useful. If you want to find out more about our podcast, visit our website, yourpregnancyweekbyweek.com. If you're looking for something specific, check out the podcast topics list. It details topics covered in each podcast, so you can listen to a particular podcast or read a certain chapter week if you want more information, or if you want to check out something you missed or a topic we haven't covered yet.